talk about brain injury guidelines. Dr. Wertin, I'm one of the trauma critical care surgeons here, and this is something that we deal with quite a bit. And what we're going to try to convince you of is that we're doing it wrong, and there's no evidence of what we're doing, and we need to do something better than what we're doing. And we're going to focus on a paper that was written by Dr. Ree, who's a big trauma surgeon out of University of Arizona. He's actually the one who took care of Representative Gifford when she got shot through the head. He's also a friend of mine. I've known him. He gave me my first test in ATLS when I was a medical student back in the day. He's now currently at Grady. So brain injury guidelines, this is the name of the paper that they came up with. And so my disclosures, I'm not smart enough to have investments or otherwise. So the learning objectives, like what's behind all these increase of admissions for traumatic brain injuries? Does everybody need an admission to the ICU? Do they all need a repeat head CT scan? And then the last one is, what are the outcomes of our best current therapy? So my big thing is, when is everything too much? And when you start to see octogenarians falling down, hitting their head and having blood in it, and their best outcome is going back to the nursing home or death, why are we spending an exorbitant amount of money to admit these patients to a limited resource such as an ICU, and then when there's no hope for recovery versus operative management of these patients? So the TBIs have increased by 20% over the last 10 years. There's more than 1.5 million annually. Multiple reasons why these TBIs start to happen. One, we have an aging population, so there's more people falling down and hitting their head. The other thing is, think airbags, because now you don't die from the car getting driven through your chest. Now you die because of your head injury. Our CT scans are phenomenal. Back in the day when you had a two-slicer, you chose who you were going to CT scan, so you didn't. Everybody gets one. We make a joke that you should roll a patient through the scanner as they come into the trauma bay, and it'd save us time. There's a diverse population that's affected by it, and the age has an issue, coagulopathic, whether we initiate the coagulopathy or not, and then the hypotension that you see going along with patients who are on medications and they fall and everything else. So right now, any patient that has intracranial hemorrhage gets transferred to a trauma center. And that's that's what we do. There's no science behind it, but somebody sees blood in the head and they have to get it to a neurosurgeon, which back in the day when you only had a few people, that was probably an appropriate thing to do. But as a general surgeon, if you called me every time anybody had gastroenteritis and wanted a consult on it, even though it was non-operative, you tend to get a little tired of seeing non-operative head trauma, and you'd want to try to fix that. So what we have to do is recognize that elderly and falls, we first recognize this with the hip fractures, that patients who are falling and breaking their hip, they usually break their hip and then fall, or if you fall and you break your hip like this and you're unable to protect yourself as you're falling, that's a level of frailty. That means you have a pretty big predictive value that you're going to die within that next 6 months. Well, now we have to say falls as a measure of frailty. Now, these are patients that are just falling, and everybody knows there's a difference between an active 65-year-old and a very frail 65-year-old. You can see him in the bed and you go, wow, that's an old 65. And we have to remember that the fall is a symptom. It is not the cause of what's going on. And yet we focus on the outcome of this blood within their head, and the reality is there's other organic factors that are ongoing, and it's not the blood in their head that's what we need to work on. Because 99% of the time they will not receive any intra or operative intervention. All right, so our reflex right now is we admit them to the ICU. We give them Q1-hour neurochecks. We repeat that scan in 6 to 12 hours, and we put them on Keppra right away. I will tell you, if you review the literature on any of these, which I'm going to try to convince you that all this is wrong, and it is okay when you're at a different level of head injury, but for what these routine patients are that come in, it's wrong, and that we need to start doing evidence-based treatment instead of just a generic cookie cutter for everybody. Keppra, from the most recent Cochrane review shows no benefit in prevention of post-traumatic seizures, and that it's the level of injury to the brain that actually results in the seizures, not the medication or whether or not they had it. Q&R neurochecks. You can imagine if your patient is elderly, they live at home, they have a very good routine, they're probably very functional in that very small environment. Now I'm going to pull you out of that place. I'm going to put you into a room that's dark, noisy, cold, and then I'm going to torture you every hour and wake you up to make sure you don't sleep. And it only takes about 24 hours, and I'll put these patients in a pretty significant delirium. And that results into a long-term outcome of that they don't go home ever again. They go to a nursing home, and they never come back. So are we depriving those patients the ability just to go home and be fine? Okay, so we talk about this is my real concern right now, and it's something that I've seen over the past years, and we're actively going to start looking into the outcomes associated with that. All right, so this is Dr. Ree's paper. What he did is he said, okay, let's look into our database and let's see who doesn't benefit from anything we do to them. And that's where they started. That's basically where this paper is. It said, let's find out who's the safest patients to not admit and not do anything with, and we'll see what happens with those patients. And so they categorized it into a big 1, 2, or 3. Makes it easier. It's an easy catch thing. So the big one is that they said they went through these factors, the risk factors for progression. Basically, they said if it's small, their GCS is either a 15 or 14, and it's in one location, you can observe them in the ER for 6 hours and you send them home. Now, anything that causes you to be concerned about increasing size of that hemorrhage goes into big 3 category, like an anticoagulant of any type, even though I'll show you that paper that's proven that doesn't happen either. And then the big 2 is where we kind of have that handshake with neurosurgery. Maybe we consulted and maybe we didn't. So none of these would get a consult to neurosurgery. These guys definitely get a consult for neurosurgery. They get the full core press. They get the repeat CT scan. They get the Q&R neurochecks, etc. These guys right here get a neurosurgery consult if the attending surgeon decides that that's a necessity. All right. So what did they find? They said, big 1, no intervention, no clinical worsening. So all we had at that opportunity was make them delirious, make them no longer able to go home, and we kept them in the hospital and we tortured them with the standard therapy, what we should have done based on this paper is if you see a small intracranial hemorrhage after a fall and the patient's normal, you send them home and you make sure they got somebody to take care of them and a follow-up with a family practitioner. The big 2 had a radiographic worsening of 2.6%, but there was no evidence of any kind of intervention done. And then the patients that they categorized as big 3 is anybody who needed surgery was in this group. So these 2 groups required no surgery, so this is the group that we're looking at as who deserves an admission to the ICU, who deserves a neurosurgery consult, so that they're not seeing patients in these categories where they have no opportunity to operate on them. So then they did the next step, because now they said I did a retrospective study, this is what we think, and then they did a prospective study, and they validated their parameters. And what they came up with is they said 127 patients in one arm, 120% patients the other side, neurosurgery consult, no neurosurgery consult. There were no interventions in either group, and there were no differences in outcome. And there's still the progression that we see on a CT scan, but that progression on a CT scan does not matter unless it causes neurologic changes, which would then lead to maybe a operative intervention. All right, so now we say, okay, that was from the same author group. Let's see who else has a dog in this fight. So this is at a level 3 trauma center, and they said, is it safe for us to use the same big criteria to manage these patients in-house? So they did a retrospective review as well to see what it was. And this whole paper is kind of driven at why are they evacuating patients who meet big 1 to us? So they take an 80-year-old lady who fell down in Monroe, and now they send them on a helicopter to us. We throw her in the ICU, torture her for 24 to 48 hours, Then we have to figure out how to get her back home. And then her family is from Monroe, so they have to drive back and forth. So the dislocation of this family and that support group makes a big difference for these elderly patients. What they said is, yes, this works where our hospital is. So I said, okay, now the surgeons, the trauma critical care literature says that. Let's go look at everybody else's literature who has, a buy-in to this procedure and process. And so this is from the Journal of Neurosurgery. And it says, repeat imaging necessary? And basically it says, no, you don't. Unless there's a significant injury, there's no reason to do it unless you have a cognitive decline. Now, all bets are off. So if you have them you're observing them and they have a cognitive decline, then you have to get a repeat CT scan, and you'd have to get a neurosurgery consult. What does emergency medicine say? Emergency medicine says, hey, we can look at these guys in our own literature and not in this paper, and say we can look at patients with subarachnoid hemorrhage as long as they're stable, their GCS remains stable. You can observe them in the ER and they can be discharged to home. So again, we're preventing these patients, usually are elderly, from being admitted and having their lives disrupted, and they should be able to go home. Again, if we had any benefit to these patients, we provided any benefit or any operative intervention or anything that made it better, then it would be okay to admit these patients. But we don't do anything for them. We basically just make them worse. All right, so critical care. We all know that as our population is aging, we're going to see more and more of this, because we're just on the tip of the wave of the baby boomer population. And so everybody loves Pradaxa, everybody loves Coumadin. If you're not on it by the time you're 65, just wait. They'll find some other reason to put you on it. So this is a very valuable place in the hospital to be. And so if you're not going to get a benefit from being in that ICU, then why would we want to spend the money of putting you in that ICU? So that was emergency medicine, neurosurgery, trauma critical care surgery. And then we come to JAMA. We know what JAMA does. JAMA takes big population studies and says, hey, this is how the policy of the United States should go. And basically they said, yeah, there's no really even incidence of bleeding after they have a negative CT scan. So we have to admit patients who have a history of anticoagulation. They don't have a bleed on their first scan, they're probably not going to have a bleed or have a problem in their second scan. But again, we're still stuck in that mode of if you're on anticoagulation, it causes, we have to worry about a secondary bleed. And really the data does not support any of that. And then also, our big thing is being able to push patients through the hospital and appropriately using our consultants as we need them. Again, like I said, if you consulted me for gastroenteritis on every patient you admitted to the medicine service and you knew it wasn't operative, but yet you still called me and said, well, this is what we do, you'd get very tired of that, and also it takes away from the patients that the neurosurgeons really need to focus on and take care of. All right. So again, another one, low altitude falls. You don't have a positive CT on the first CT. You don't need to repeat the CT just because they're on some sort of anticoagulant. The other thing is that everybody who walks in the door gets a CT scan. And that what this paper said was you need to kind of narrow this down to your physical examination so you don't go looking for all these minor head bleeds that don't turn into anything but turns into a big expense. And it all comes down to the legal issues and the, what if something bad happens to them. And so we're trying to move through that. So the early predictors of mortality for geriatric patients, it just means that you're going to die, and if you fall from a standing height, you're not going to do as well as somebody who's driving their Porsche and wraps around a telephone pole. If you're 65 and you wrap your Porsche around a telephone pole, you're probably going to be fine because you're up running your Porsche too fast and you wrecked your car. If you fall in your house over your rug that's been there for 16 years, you're probably not doing okay. And again, this goes to that survivor, this is out of orthopedic trauma surgery, saying that if you are in a high velocity injury as a trauma patient and elderly, you do better. which makes no sense unless you factor in the fact that it's a frailty issue and that the underlying organic disease process is the real issue. Okay, so what does it all mean? Well, it means that we need to readdress what we're doing right now. Our current management, it's not evidence-based, and we need to start gaining evidence on it. We order way too many CT scans. And we have to always take in the fact of the age and the mechanism before we start down this road of heroic efforts. If you're 18 and you have a head injury, that's a lot different than when you're 88 and you have a head injury. So the expectations, life expectancy, quality of care, all come into play. And then also, this is just going to get worse. This is just going to get worse. And they're going to continue to show up, and we're going to continue to be inundated with old people falling. All right, so we'll come back to this guideline. Now, they were able to coordinate with the emergency department, the neurosurgery, and also the trauma critical care service so that they could come to grips with this part. We're currently pulling data to validate it in this facility as well. And our whole idea is that we're going to start with this, meaning we don't want to consult neurosurgery for a big one, but we'll go ahead and admit them. Because everybody's a little bit dicey about sending some guy out with a blood in their head. We have the data to back it up that it's probably safe, but we don't quite know yet. And so we're going to pull the data from our hospital too, and if we can justify that, then eventually these patients will just go home, and you won't admit them anymore. This patient will not get a neurosurgery consult unless there's a change in their status, and then we initiate that. And this group of people will all receive a neurosurgery consult, repeat CT scan, etc., the standard therapy, what we see today. Again, if any of this stuff that we do, if it's usually, for our elderly population, it's less than 1 or 2% that actually receive an operation. And if the only reason you're admitting them is for neurosurgery care and whether or not they're going to operate on them, then we're spending a lot of money that we don't need to. And not only that, we're taking these people out of their situation and putting them into a torture chamber that may or may not be beneficial at all. All right. So, benefit of admitting elderly patients to the ICU for mild head trauma. Again, don't ever trust anybody. I have like 15 different references for this that I pulled out, and that was just easy to find. And the biggest thing we have to do is address goals with the family. Because what they'll tell you is that grandma was doing great. She gets around great. Everything's great. And then you find out that, well, no, because you don't go see grandma. And grandma tripped over and hit her head. But they saw grandma, as somebody who is active and happy. And then you have to go like, okay, what was she really doing? And what is your expectations once we get through with this? And is she going to be independent ever again? And so all these have to be played into the family and those dynamics that go on with it. All right, so this is a short talk. It's more designed to get reactions. I know I got a neurosurgeon back there, so it's one of those things that we're trying to do. When we do research, at least when I do, I always find a problem that makes me mad, and then I pull all the papers to try to find out why it's doing the way it's doing, and then you start to fix that problem. And so this problem is what I see is that we're admitting all these head injuries that don't have any reason to be here, and we're spending lots of money, and we're bothering the neurosurgeons for every one of them, and we're not doing anything. We're just basically churning the system. And the churning the system is hard to stop once it gets going. And if you get me started on C-collars, it's the very same thing. Everybody talks about the C-collar goes on before anything else, and you ask people, have you ever seen anybody get pithed by not having a C-collar on, meaning it immediately they get paralyzed because you move their head? The answer to that is no. And so it's not in the literature, it doesn't support it, but yet the C-collar got started, C-collar's on. So, and that's all that pre-hospital stuff. So I think this is one of those things we have to overcome the inertia of past medical practices. We have to overcome the inertia of oh goodness, we're going to get sued by everybody. And unless we, as a organization of medical professionals, come together and say, this is not standard of care, this is standard of care, and we have to migrate that out. So we're just starting to see that starting to happen. So we can either be a part of that solution or you can be a part of the problem and continue to just waste resources and money. Any questions at all? Go ahead.
Thank you for giving this talk. I think it's very relevant for sure. I'm one of the residents for neurosurgery. Did you find anything in the literature on like level 1 or 2 evidence about giving, say, platelets to people on antiplatelet therapy? And there's like the patch trial, but that excludes traumatic lesions. And they found that you give reversal to antiplatelets, it actually did worse. And that's one thing I think that we could talk about too at some point is maybe these small traumatic subarachnoids in a patient with fresh heart stents should not receive platelets. And I know it's kind of a part of our pre-type note is like, oh, reverse it. And but I think this is all good things to consider, like especially the anti-epileptics are probably not needed for traumatic subarachnoids, or unless like maybe if it's like a big bleed in like the temporal lobe, you could argue, but definitely not for 30 days, 7 days at the most, I think. And
we go back with the other side of the side effects of Keppra is lethargy, unsteadiness, elderly population, again, to fall. And what I was able to extract from the literature was that Keppra prevents postoperative seizures associated with hemorrhage, but what the Cochrane kind of said is maybe it's the severity of the injury when it comes in, and it's not necessarily that you need to give it for everybody, but it's one of those things that it looks like nobody's bothered to do the work on it to prove it one way or the other. And platelets, I don't think, help anybody. We operate on Pradaxa now because there's nothing to reverse it, so you just go and operate. 10, 12 hours later, hopefully it comes off. It works. But, and then there was another study that was done, God, I can't remember who did it, but it was from New England Journal of Medicine, and they used factor 7 in intracranial hemorrhage. They could correct the coagulopathy really fast, but the injury to the brain was already accomplished by the fall, and so it doesn't help to stop the bleeding because the bleeding's already done. But I think if we start moving forward and we start drilling down into these patients and saying, "Are we helping you?" I'm not convinced. I drank the Kool-Aid my entire life. C-collar went on when you're in the field. Don't ever take it off. You need an MRI to clear it if they're not awake. And then we gradually got through that part. And now we're using the same brain injury issues that we've had back since the 60s. And we really haven't progressed forward on it yet. And I think that's an area of research that could really, really help out, especially for us. And again, we come from the side of the fence of, we don't want to pick on, get you guys involved in stuff that you don't need, You're like, yeah, he's got some blood in your head. All right, go. We're not going to operate on him. Hey, they're 96. They got end-stage renal disease. They have metastatic cancer, and they fell down. And you go, yeah. And those are the things we have to come together and say, I don't need to bother you for that. We can take care of it. But we also need to validate that study so everybody feels good about what we're doing, and then work closer together so that there's an issue, we can just call y'all.
So you would suggest then that like big level 1 and 2 could say, for sure level 1 could be admitted to say a step-down unit at the most instead of a...
Well, and what I'm trying to say is admit them to the floor. They're sending them home. They sent these patients straight home. They went to the ER, they got a CT scan, they were evaluated, and they got sent home. And so what I'm saying is, okay, we won't send them home. We'll put them on the floor. Because sending them home, again, makes everybody a little bit crunchy right here, right now. But once you say, our data shows that these patients don't need any intervention, they don't get better, and I think the delirium on top of all that will hurt those patients. But it's just that, unless you want to see every patient with a little bit of blood, I know you guys like that. But it just doesn't make any sense. And my big side of this is I want to be able to say, eventually, let's take a treatment group where we do big ones, send them straight home, do a follow-up study on them for a year, see their life, how long they live, how much independence, quality of life, versus people we admit, and then disrupt that whole organic portion of their brain that tells them my bed's over here, my toilet's over here, my dog needs to be fed, and that very rote, routine that they have, and we take them out of that, and then they're never the same again. And then they end up in a nursing home, and then they end up dead. And so, again, I feel that maybe we are hurting them more than we're helping them. And that's what I'd like to prove, and like this, keep moving this to take care of the patient, not necessarily just the head bleed. Anybody else? Ma'am.
Right now, funded by the Department of Defense with Neurosurgery, actually, with Dr. Sun and the Neurology Department, looking at traumatic brain injury. It's a prospective study, 18 years old and above, looking at risk factors for epilepsy, the need for anti-epileptic drugs, and stratifying patients about their need for that, depending on the degree of brain injury. So if you have any patients, 18 years and above, we'd be interested to know about them, because we can enroll them in the study.
Sweet.
It's ongoing right now. It's funded by the Department of Defense.
We have quite a few.
Yeah. So if you have a database,
Yep.
maybe we can collaborate with
Okay.
you.
Perfect. But yeah, that's how you start. See a problem, fix a problem, and it takes a little bit of time because it's hard to get the train stopped once it's started. But we're obviously not doing the right thing. I'm pretty basic knuckle dragging belly surgeon. If I can point it out, it's probably a problem. All right, you guys good? All right, that was quick.